Good morning, all of you. So today I am going to cover the topic, the factors related to elimination of human hepatocyte during liver engraftment. So we all know that loss of cellular or functional loss of hepatocyte are the major cause of liver failure in all kind of liver disease, whether it is a injury related or whether it is related to the metabolic dysfunction of the liver. And in such cases, till date, liver transplant is the only curative treatment. So despite success of this liver transplantation in clinical setting, still it is not has become as universal due to some limitations like relative shortage of the donors, operative risk, and high cost. Apart from this, liver transplant also has some lacunae, like one graft can be used at the most for the two recipients. It involves a major surgery, and after the graft failure, the donor organ have to be immediately transplanted. Graft failure is always life-threatening in this condition. The native liver is removed, so there is no chance of recovery for the native liver. And though it is a curative treatment, but it requires a long-term immunosuppressive, which also causes the chances of infection. So to overcome these challenges, very early in 1976, the Mathis et al. Has shown that, have given the proof of concept that rather than using the complete organ, if we can use hepatocyte per se, it can also be able to rescue the metabolic dysfunction of the liver. So after this proof of concept, various preclinical studies has been shown the efficacy of this procedure, and then in this case, rather than using the complete organ, the hepatocytes are isolated from the donor liver, and these hepatocytes either cryopreserved for future use, or it can be immediately used for the and infused into the diseased liver, and they found that there is some kind of improvement in the liver function. So theoretically, in comparison to the transplant, the multiple recipient can benefit from one donor. This is a less invasive procedure. Hepatocytes can be cryopreserved. Patient revert to pre-transplantation state in case of cellular graft failure in comparison to the OLT. The native liver is left in place, so that is allowing their self-recovery and leaves open the option for gene therapy also. So with this concept, the various clinical studies has used the hepatocyte transplantation as an alternative to orthotopic liver transplantation, particularly in the two case setting. One is the inborn error of metabolism, and second is the acute liver failure. So in inborn error of metabolism, despite so many patients has been tried, but all the studies shows that the average graft-free survival was only 13 months. So that means after 1 year, the grafted cells are not able to perform its function, or either they got resected. Second, in case of acute liver failure, so till date, total 36 patients has been tried, and out of this 36 patients, only 22% cases they observe the complete recovery, while in 78% cases either there is a death or there is a liver transplantation. Very early, this concept was also emerging that when we do the hepatocyte transplantation, so only even we target the 3 to 5% of the total liver volume, the engraftment rate is only 0.03 to 0.05%. And almost 90% of the transplanted hepatocyte get lost during this process. So what is the cause of this loss? So we will be basically discussing about these causes in the subsequent slide. So this was very well proved by Gupta et al. In 1999 that when we do the hepatocyte transplant, the first thing within few hours there is a congestion of the portal vein, which get clear, and this congestion lead to the slight increase in the portal pressure, followed by 24 hours this is resolved. But however, when they did the histology, they observed that by 2 hours, most of the hepatocytes are in the portal vein area, and they are forming like a emboli formation there, and that might be the reason for subtle increase in the portal pressure. At 24 hours, they observe there are some hepatocytes in the sinusoidal beds. However, almost 70% hepatocytes which were present in the portal vein were lost during this process. And they also observe that not only the hepatocytes were present in the portal vein area, but they were also surrounded by the various type of immune cells. They were also infiltrating into this area. At 24 hours, though the portal area was cleared from the both hepatocyte as well as the immune cells, but even in the hepatic bed, the hepatocytes were surrounded by some kind of immune cells. So that means there is some role of immune cell-mediated rejection or the killing of these transported hepatocytes. So what happened that further study shows that unlike the hepatocyte which is present in the liver, when we isolate these hepatocytes, so this isolation process leads to the exposure of this tissue factor into these hepatocytes. Also the various cadherin receptors which were initially masked in the native liver, they get exposed, and that exposure basically leads to the recognition of the tissue factor and the activation of the coagulation and complement cascade pathway, finally leading to the formation of fibrin clot as well as the lysis of these cells. This cell lysis lead to the recruitment of various immune cells, particularly the Kupffer cells, monocytes, neutrophils, and natural killer cells. Later, with this finding, the Corrin et al. Has shown, they repeated this experiment in more extensive manner, and what they found, similar to the Gupta et al., they found that by 6 hours, most of the hepatocytes are in the portal area. By day 1, they start invaded into the hepatic bed near the sinusoids. By 1 week, there is a significant decline in the number of the hepatocytes. Interestingly, what they also observed that even at the 6 hours, there is a huge increase in the various chemokines and cytokines that is related to the innate immune cells. They further characterize that these immune cells are mainly of the neutrophils and the monocyte macrophage lineage. And they prove that if they deplete these cells or they stop their activity, it significantly increases the initial engraftment of these cells into the liver. There is another study which shows that not only in the initial phase, even the cells when they reach to the sinusoidal area, at that time also they were surrounded by the Kupffer cells. And they also shows that if they deplete the Kupffer cells, it more than twofold it increases the engraftment of the donor cells. So that means the Kupffer cells mediated clearance plays an important role in the initial clearance or the loss of the hepatocyte during the hepatocyte transplant. So in summary, the cause of 70% loss of the donor hepatocytes is that when these hepatocytes reach to the portal vein, there is a binding and activation of coagulation and complement system. This leads to the infiltration of the leukocytes, followed by cytolysis mediated by the neutrophils, monocytes, and activation of the Kupffer cells, and finally the phagocytic clearance of the hepatocyte by the Kupffer cells, and ultimately we got only 0.1 to 0.3% engraftment. So even though these cells get engrafted, then why after 1 year we don't see the survival of the graft? So this could be because of two reasons. There is a rejection of the donor cells, or there is a lack of repopulation. So this rejection aspect was also very clear from the very early in the 1998, so where they try to see that whether the allogenic or syngeneic hepatocytes has a different survival rate, and indeed they show that in comparison to the syngeneic, the allogenic hepatocytes has the poor survival, long-term survival. Further, these authors have shown that which cells are basically involved into this, and for that they have used the animals which is having the knockdown function of the B cells as well as the T cells. So what they observed that the T cell down is, if they knock down the T cells, the survival is far better in comparison to the B cell knockdown or the control. So that suggested that T cells has the major role in the rejection of these cells. And that also proved in this natural setting of the SCID and nude mice. There also they show that there is not significance, but there is still a higher engraftment in case of the SCID compared to the NOD mice. This was further proven by the another way that rather than knocking down the function, so in this study, they have used the animal which is already lacking the T cell and B cell function, and then they reconstitute the T cell and B cell into this. And what they found that when they reconstitute CD8 T cells, the graft survival was the lowest, followed by the CD4 cells, but they didn't observe any kind of alloreactive antibody. So that is ruling out the role of B cell, particularly in the rejection of these cells, and mainly the involvement of the CD8 T cells. This was also confirmed in the clinical case study where there is a graft rejection after hepatocyte transplantation. And in this patient, they observed there is no humoral immunity does not contribute to the allograft rejection. But yes, they observe a very huge amount of HLA class 1 specific T cell response. So that is suggesting that these hepatocytes, the donor hepatocytes, MSC, their allogenic peptides or tissue peptides are get recognized by the CD8 T cells of the recipient, and that basically leading to their activation and the apoptosis of the donor hepatocytes. So in summary, yes, the initial 70% loss of the hepatocytes are mainly caused by the innate immune cells, but later on, once the cells reach to the liver bed, they got rejected because of the T cell mediated clearance of the engrafted hepatocytes. In animal study, yes, there are various approaches has been tried to overcome the early loss of transplanted hepatocytes, but yet their clinical translation is awaiting. So there is no clinical studies has been used till date to use this kind of modality to increase the engraftment. Yes, like OLT, the immunosuppressants are also used in hepatocyte transplant, but unlike that, till date there is no consensus about the protocol that how much and which should be used in most of the center. For induction, the steroids are used, and for the maintenance, these kallikrein inhibitors or tacrolimus or steroid, anything, they varying upon the center to center. Adjusting the level of immunosuppression is difficult in case of hepatocyte transplant because we don't have the reliable marker for graft function or graft rejection in these cases. The third concept is that why, even we know that Hib liver has a huge amount of regeneration capacity, so why the donor hepatocytes were not able to reproliferate or repopulate when they reach to the hepatic bed. So this concept was given that if we can give the additive advantage to the donor hepatocyte in terms of regeneration, the chances of engraftment can be increased. So what these authors have done, that they have to show the proof of concept, they have used the donor which is having the DPP4 positive and the recipient was the DPP4 negative. To remove the cell cycle proliferation of the native hepatocyte, they have used the retrosterin which can block the cell cycle, and to induce the regenerative signals, they have used the partial hepectomy. And here they shows that the animals which they have gone through this process, in comparison to
Anupam,
that, if
Anupam, can you just tell us what is this DPP4 positive and negative?
So this is the enzyme, ma'am, which is present in this animal, which is the hepatocyte. They are used as a genetic tagging marker. So this was present in the hepatocyte, and to see that whether if we can use the immunohistochemistry or the activity for these enzymes, we can mark the hepatocyte which is the donor. And the recipient was negative for that. So the recipient hepatocyte will not show the immunohistochemistry positivity for that, while the donor hepatocyte will show that. So in comparison, if you compare the 30 days transplantation, after that engraftment is very poor in the control comparison to the the animals where they have used this adaptive regenerative response advantage. And even at the day 60, they found that there is still there is a significant increase in the number of donors, engrafted donor cells into this. This concept was further strengthened by this very elegant study where they have developed the humanized animal model. So what they have done, they have used the RAG2 and IL2RG negative mice, which is lacking both T cell, B cell, and NK cells. And the FAH negative they have used as an adaptive advantage of the donor hepatocytes. So these animals can only survive if we give the NTBC to this. And then they cross these animals. So the animals which produce from the crossing of this, they are negative for FAH, they are RAG2 negative and IL2RG negative. The advantage of these animals are that they show normal growth with NTBC in their drinking water, completely lacking T cells, B cells, and natural killer cells, and fast negative, so they are selective advantage of FAH positive hepatocytes. More interesting observation in this study was that for the human donor cells, they have used the age group, if you can see, from the child to the even at the age of 64 or 59 years of the age. So basically this saying that whatever the age of the human donor was used, so they saw significantly increased engraftment, and that also showing the repopulation in terms that with the time the albumin, human albumin production was going higher and higher, irrespective of the age of the donor hepatocyte. So that means age is not a barrier for the human hepatocyte in terms of regeneration process. They also use the primary and secondary generation. So from the animals first generation, they taken out, they retransplanted into the second animals, and then they taken out this, put it into the tertiary animals. So there also they say that not only single time, even the multiple times these hepatocytes can repopulate. So these hepatocytes, if given a proper condition, they can repopulate and they can regenerate. So what is the cause that when we do the hepatocyte transplant, so why they are not able to proliferate inside the liver? So if you take the inborn error of metabolism, these are usually, they have a normal architecture, liver is healthy condition, and they don't have, healthy liver don't have the inductive regenerative signals. So we have to do something which can induce or prime these liver to induce a regeneration process. While the second condition like chronic liver injury or the acute liver failure, there the regenerative signals, the anti-regenerative signals are very high, like TGF-beta is very high in this case, which can not only causes the senescence of the recipient hepatocytes, the donor hepatocyte also goes to the senescence, and that basically lead to the poor engraftment or the colonization of these cells. So for preconditioning the liver, the three approaches has been tried: the hepatic irradiation, portal vein immobilization, and partial resection of the liver. So I will not go to preclinical studies, so directly I'm describing what is the success we got from using these techniques in clinical study. So this was the first, like hepatic irradiation. In this, the authors has first proved the proof of concept in the non-primates using the donor hepatocytes were taken from the porcine and the recipient was monkey. So there they have shown that using the irradiation, it significantly improves the engraftment of the donor cells. Confirming this, they used in 3 patients, and I will discuss each of them and the results. So the first patient was the CPC-S1 deficiency, and at 4 months, they got the hepatocyte transplant. So before giving the hepatocyte, the patient were subjected to 5-gray radiation, which is consisting of almost 33% of the liver mass. The hepatocyte total they infused were the 6.89 into 10 to the power 8 viable cells in 4 sitting. The first dose was given just 6 hours after the RT, and subsequent dose were given within 26 hours. Even though the graftment, they successfully used the hepatocyte transplant, and there was no safety issue, but in the follow-up, what they observed that the donor-specific antibodies were not detected. Patient continued to have an episode of high ammonia despite being on a limited protein intake and full dietary medical support. So that means the graft, which the donor hepatocyte was not performing well. So in lieu of that, immunosuppression was withdrawn and the patient was subjected to whole organ transplant. The second patient was the OTC deficiency. In this, the patient was subjected to hepatocyte transplant at the age of 7. In this, they have used the 7.5 gray of radiation consisting of the 37% of the total liver mass, and total cells they have used 2 into 10 to the power 9 viable hepatocytes were used. In this case also, though from the previous there was some improvement in the initial stage, but again there was a rejection after some time, and there is a persistence of the hyperbilirubinemia episode. So in that case, they again withdraw the immunosuppression, and at the around 11 months after transplantation of hepatocytes, the patient was gone for the solid organ transplant. In third case was the PKU deficiency. So there they have also taken the serial liver biopsy to see that whether the hepatocytes are there or not. So at 3 months or 6 months, though they found the hepatocytes were there in the liver, but what they observed were post-transplant, though there is a significant decrease in the PHE level, but after that, after some time, around 200 days later, there was a slight increase in this level, which though they become normal, but still the level was very high in comparison to the other individual. So the question was that whether this PHE level is a direct indication for the graft failure or not. To confirm that, what they have done, they have taken the patient and healthy, as well as they have also taken the measured the whole body oxidation of this, and what they observed that the patient and both their brother, they are having a high level of PHE activity in comparison to the unrelated healthy control. So they confirm that this initial subtle increase is not because of the graft failure, and then they withdraw the immunosuppression, and the patient returned to her unrestricted diet and maintained the mean PHE level at 854 plus minus 14, and still it is survived. So this is out of 3 patients, only 1 shows the success of this method. The second is the portal hepatic resection. So this was used in 2 patients, one with the 30-year male, both having a UGT1A1 mutation. And what they observed that, so what they did before they giving the transplant, the patient was gone for the partial resection of the liver, and then the hepatocyte was transplanted into this. But in both the cases, if we can see that after 300 days, there is an increase in the HLA class 1 and HLA class 2 level in the serum, and patient required the transplantation at around 2 years. So this also confirming that there is a role of T-cell mediated rejection in the graft. So even though it can improve, but it is not a complete cure of the patient. So again, patient needs the liver transplant. The third condition is the portal vein immobilization. So there, studies have shown that portal ligation or immobilization can induce the regenerative response. So this study is done in the non-primate, where they have used that, yes, using the partial portal ligation increases the regenerative response. But what they observed was that in this case, the hepatocyte transplant, when they did, it was mainly localized to the portal vein. They was not able to disperse into the parenchymal area. However, when they used the partial portal immobilization, the regenerative response was also high, and the transplanted hepatocytes was not only localized to the portal vein, they also showing the significant improvement or increase in the repopulation of the donor hepatocytes. Then increasing the tolerance. This is also concept that when we isolate the hepatocyte, this is a very primitive finding. So what they have shown that in this study, that this is a completely in vitro study where they have shown that if you can culture the hepatocyte with their non-parenchymal cells like mesenchymal stem cells. So if you can see here, after 7 days or 8 days of culture of the hepatocytes, hardly you can find any viable hepatocyte in this one. But when they are co-cultured with the mesenchymal stem cells, they are still viable. Not only viable, their functional is also very significantly high in comparison to the 2D culture of alone. So that also suggests that this can be also used rather than using hepatocyte alone. Hepatocyte can be transplanted together with the non-parenchymal support cells. So this is all the case of the inborn error of metabolism, where you have the native liver is not conducive for the liver regeneration. Second condition is the acute liver failure. So apart from, it's in this case, the liver is not only non-conducive for the regeneration process, but there is also a very highly toxic and inflammatory environment in the liver. Top of that, hepatocyte cannot be directly infused into the portal vein because of the coagulopathic disorder. So another approach is used that can be used the ectopic hepatocyte transplant. But they are highly susceptible to the immune-mediated clearance. So to overcome this, in this, they have this, from Dr. Anil Dhawan's group, they use the alginate-coated hepatocytes. So here also what they do, they take out the hepatocytes, and the cluster of hepatocytes were coated with the alginate beads, and then they are infused into the peritoneum of the patient. So first, they have used in the preclinical model and shows the success of the method and their safety, and then they have tried it into the 8 patients with the acute liver failure. And here I am summarizing that out of this 8 patients, in 4 patients, they found there is a full recovery. They don't need any transplant. In case of 3 cases, they need transplant. However, only 1 patient died. Most interesting finding in this was that the patient who went for the liver transplant after this procedure, they isolated the alginate bead from their peritoneal cavity. And what they saw here, that still after the rejection was there, or the patient need the transplant, but this alginate hepatocytes were viable, and the beads were all taking the viable hepatocyte into this. The third is that, particularly for the inborn error of metabolism, that rather than using the allogenic hepatocytes, can be used the same autologous hepatocytes using the gene correction. So this is again a preclinical concept. So in this study from the Scott work, they first tried it in the rodent model of FH, and then they have shown in case of the higher animal model like pig, and they saw that what they did, they taken out the hepatocyte of a deficient animal, then lentiviral gene transduction were there, and then the same hepatocyte were transplanted back into the animals. Here they show that this procedure has huge advantage, and when the NTPC was withdrawn, almost nearly all the hepatocytes with the time get replaced by the donor hepatocytes. So in summary, if we talk about the journey of hepatocyte transplantation, yes, when we infuse the hepatocytes, most of them get lost into the portal vein, and then there is the innate immune clearance of the donor cells. This can lead to the 70% loss of the cells. To improve the process like high viability, quality of the cells, increase the tolerance using the MSC, inhibition of adaptive immune-mediated clearance can improve the engraftment of the donor hepatocyte at this stage. After this, the proliferation of the transplanted hepatocytes, so the natural graft advantage like partial hepectomy, irradiation, or portal vein immobilization can be used. Once engrafted, the allogenic hepatocyte liver repopulate, but later there is a donor hepatocyte loss or graft failure. So then again it is the immune rejection and the lack of tolerance. So the approaches like immunosuppression adjustment, co-transplant with the immune privileged cells, autologous hepatocyte with gene therapy, or encapsulation in alginate can be tried to prevent or improve the graft survival in case of hepatocyte transplant. Thank you very much for your attention.